I believe I find you all well, in good health. My name is Chitumba. In this module, I'm going to discuss, as you know that every year in November we take this month to commemorate fallen heroes, to help each other with awareness on prostate ultrasound. So I'm going to take this opportunity to briefly capture the statistics that we have in hand on prostate ultrasound, the demographics on the people who've died from prostate ultrasound, and where we stand as professionals, what we must do differently. We have been doing ultrasound, we have been doing prostate ultrasound, but without knowing the dangers or the immediate danger to the patients or to the community of prostate cancer, we overlook it. So what I have here are the statistics from WHO on prostate cancer. So I'm going to briefly share that background so that you understand or appreciate where we are coming from. So what is the problem that we have? Why is it that we are so much concerned about prostate cancer? Just like breast cancer, just like cervical cancer, we are supposed to teach the world, educate the world about this type of a cancer, conscientize them about the risk, and also people must know that awareness can change or transform the way we view this type of a condition that is rarely taken serious by most people who present late. So the problem is cancer is one of the leading causes of death, account for nearly 10 million people who died in the year 2020. Unfortunately, I don't have the current statistics, so who hasn't updated the current statistics? So this is what I have. I have statistics dating back to 2020. You can see how menacing prostate cancer can be or has been, killing almost 10 million people in the world. This is a going concern. Something has to be done about prostate cancer. It has to be stopped. So you can see the distribution of the incidence of this type of cancers, from breast cancer, which had 2.26 million cases, lung cancer had 2.21 million cases, colon and rectal cancer had 1.93 million cases, prostate cancer was standing at 1.41 million cases, and skin cancer, non-melanoma, was standing 1.2 million cases, and stomach cancer was standing at 1.09 million cases. So from these statistics, you can see we can't ignore prostate cancer. Prostate cancer is a going concern. Something has to be done. You as a sonographer, you as a radiologist, you as a sonographer, you have got a role to play. If you detect cancer of the prostate, it means the patient can be managed early and a solution can be found. You can save a life. So you can see from this table again, this is just the global statistic distribution in terms of where the highest incidence of people affected by prostate cancer are. So you can see that France has got the highest incidence in the year 2020 again, and then Ireland, then you can also see St. Lucia, Estonia, Puerto Rico, Sweden, Bahamas. So these are some of the countries which are mostly affected by prostate cancer. Unfortunately, it doesn't mean that if a country is got a higher prevalence of prostate cancer, that's where the highest death is. For some countries, their health systems are up to standard, so they can detect prostate cancer early and manage it early. So again, in the year 2020, you can see from this table, the cancer death is so worrying that in my country, Zimbabwe, it had the highest number of people who died from prostate cancer in the year 2020. So you can also see Barbados was the second, Haiti the third, Zambia the fourth, Jamaica the fifth, Trinidad and Tobago at sixth, Bahamas at seventh, and Dominican Republic at eighth, St. Lucia at nine, then Cote d'Ivoire at 10. So you can see, despite the fact that we've seen the highest incidence of people affected by prostate cancer in the year 2020 being in France, you can see the death rate was actually in Zimbabwe in the same year, meaning to say that most people, they present late in these developing countries with the poor healthcare systems. So you can see, according to the Cancer Research UK, that from 2016 to 2018, on average, 52,254 cases of prostate cancer were reported, of which from 2017 to 2019 there was a recorded 12,039 deaths were recorded, of which the survival rate in the UK from 2013 to 2017 was pegged at 78%. So you can see that in UK, most people diagnosed with prostate cancer, they can survive beyond 10 years because their healthcare systems are advanced. At the same time, prostate cancer screening is done routinely, and this helps management of these patients earlier before they die, unlike what is happening in developing countries. So we as sonographers, we as radiographers, we as radiologists, the best constituents where we can take our part in assisting prostate cancer patients is when we do our diagnosis with a distinction, when we do our diagnosis accurately. So this is the role that we can play. So that's why I have decided to take this module today, so that we have got a basic understanding of prostatic ultrasound. So just like any other type of an ultrasound scan, the first thing that you're supposed to know is you're supposed to know the anatomy. You cannot do a sonar without knowing the anatomical structures that you are dealing with. So the prostatic anatomy, essentially the prostate is a pear-shaped organ, and it's located just posterior to the urinary bladder, or just below the urinary bladder. So you can see here in the diagram that is the bladder is there, and then below the bladder you will see there is your prostate, and then you can also see by the side there that the seminal vesicles on the lateral sides, they are the rectums. Then posteriorly you can see there's a rectum there, and the prostate is divided into three basic zones. So we have got this portion that you see here is called the central zone, and then you do have got more centrally, we've got what is called the transitional zone of the prostate. Then on the peripheral or the outer skirt is the peripheral zone. So these are the three basic zones. You are going to understand the relevance of the zonal anatomy of the prostate when we are going to talk about the pathology. You are going to see that certain pathologies like cancers, hyperplasia for instance, they favor certain zones over others. So when you know the zones, it becomes easy for you to localize and suspect a pathology based on its location. So the anterior part of the prostate is also called the anterior fibromuscular stroma. So it's basically for anchoring or supporting. It's not one of the parenchyma portion of the prostate as such. So in this image, what I'm showing here is basically the prostate. This is an image from a transrectal technique. So for some who are not used to transrectal technique, it might be very difficult for you to appreciate the image in question. So the zone that is labeled here, TZ, that's our transitional zone, and then the PZ, that's our peripheral zone there. The central zone is also found in between, but it's not so much distinct when you're using ultrasound. So again, in this image, we are showing anteriorly or superiorly here, that's the urinary bladder. Then just below it, you see there is the prostate gland, and by the side, on the left side there, that's the seminal vesicle. And then there is a tubular structure coming from the seminal vesicle all the way toward the center of the prostate. That is the ejaculatory duct. And then you can see another tubular structure coming from the urinary bladder and going down through the prostate. That's the urethra. So the urethra and the ejaculatory duct, they meet at a point which we call the volumentinum. So the volumentinum is the junction of the ejaculatory duct and the prostate. So how do we measure the prostate? The prostatic volume, when you're using the transabdominal technique, like in this image, you can see these are the measurements. On transverse, you take two measurements, length times width, and then longitudinal, the AP diameter. That's how you do it. Most machines, they do have got presets, so that when you choose the prostate volume, as you do them 3 measurements, it automatically calculates the volume. But at times, some machines, they don't have the protocol, so you can basically multiply the 3 measurements, then you also multiply it by what is called the correction factor or of an ellipse, which is 0.52. Then you get the volume of the prostate. So basically that's how you measure the prostatic volume. So the prostatic volume is necessary for you to rule out benign prostatic hyperplasia or enlargement of the prostate. So what's the normal prostatic volume? The normal prostatic gland measure approximately 3 by 3 by 5 centimeters, which is equivalent to almost 25 milliliters or cubic centimeters. 70% of all prostatic cancer are basically located in the peripheral zone, whereas 20% emerge from the transitional zone and only 10% in around the central zone. So most often, or in most cases, if you find a lesion that is located in the peripheral zone of the prostate, you have to suspect it could be a prostatic cancer, because that's where most cancers in the prostate are located, about 70% times as compared to the other regions. But it doesn't mean that you don't see cancers, prostate cancers in the central zone, at the same time in the transitional zone. You can find them, but the chances are a little bit lower. So again, this image is just demonstrating the anatomy. Then if you are going to do a transperineal ultrasound scan, you just go through the back here towards the anus. But you don't penetrate the anal canal. That's where you just place your transducer, and you can see that if you are doing a transperineal sonar, the distance from the surface to the prostate is almost equivalent the distance from the abdomen to the prostate, though it's shorter from the perineal aspect than from the abdominal aspect, meaning to say that a transperineal ultrasound scan can visualize the prostate better as compared to the trans-abdominal technique. However, both trans-abdominal and transperineal techniques are not the ideal when you are dealing with prostatic ultrasound. The best technique is for you to do a transrectal ultrasound. So the basic or the ideal probe for one to use when you're doing a prostatic ultrasound scan are the transrectal probes, which are very narrow. You can also interchange them with the vaginal probe. You can use a transvaginal probe, but in some departments you find that they do have with smaller probes which are specifically tailor-made for rectal insertion. So these are some of the probes that you're supposed to be using. Of course, you must also observe infection control measures, meaning to say you must also put your protective sheet around the transducer before you do the sonar, just like you do when you're doing your vaginal ultrasound. So here are some of the indications for one to do a transrectal ultrasound scan for the assessment of the prostate gland. So when there's an abnormal PSA, which is prostate specific antigen above 4 ng per milliliter. When you have got an abnormality palpated on digital rectal examination, so when the referring clinician palpates your rectum and then they find that there is an abnormality there, or they palpate there's something, a lesion, or that the prostate is enlarged, they can also recommend a transrectal ultrasound scan. So when there's suspected infection, especially when someone's going to prostatitis, or when it complicates to prostatic abscesses, in such instance they can also request for a transrectal ultrasound. Also, for the evaluation of BPH due to lower urinary tract symptoms, which are called the LUTS. So if someone is using persistent LUTS, they can also request that you do a transrectal ultrasound scan to exclude benign prostatic hyperplasia, which is BPH. So at times also when there is a biopsy that is being done, so a transrectal ultrasound can guide the biopsy so that they take the sample at the correct site. So as I've highlighted before, there are basically three techniques that you can use to do a sonar or an ultrasound scan of the prostate, either trans-abdominal, transrectal, or transperineal, of which the transrectal is the most ideal because the transducer will be closer to the prostate and the resolution will be better. So I have said that the transperineal approach is when you just put the probe in the perineal region here around the anal region, then you can move it, slide it there until you visualize the prostate. But it's not the best or it's not the ideal examination because again the transducer will be far away from the prostate, and the resolution will not be as good. So again, when you are doing the perineal ultrasound scan, you must use the same formula of calculating the prostate, and then you can multiply it by the correction factor of 0.52 when you're not using your presets. The transrectal ultrasound technique is the most ideal, as I've said before. So in terms of patient preparation, the patient has to empty their rectum, then they must be clean. At the same time, you must also use a protective, which is a condom we do, and then you apply your gel inside the condom, and then outside. Then you gently slide it in. That is after a digital examination has been done, or when there's confirmation that there's nothing that is obstructing the anal canal, so that you don't maybe push a polyp or some lesions inside the rectum. The trans-abdominal technique requires that a patient have a full bladder, and then in supine position you can do the sonar as usual. So it can do, but the resolution of the trans-abdominal is limited. So what is it that you're supposed to document when you're doing a when you're doing a prostatic ultrasound scan? You must image the prostate in a sagittal and axial transverse views. Then you must measure the volume, as I said, the width, the length, and the height. Then also you must use color Doppler in case of suspected tumors, because most cancerous lesions, they will have neovascularization or intra-lesional perfusion. So basically you have to document all those images, the ones in B mode, and then the surgical and the axial views, and also the images for the pathology with color Doppler. So essentially, the image that you're showing, that I'm showing here, is depicting an image from a trans-abdominal technique where the bladder is full, is acting as the window to visualize the prostate just inferior to it. And the next image is again a trans-abdominal technique demonstrating the two seminal vesicles, so on the lateral side of the prostate gland. So this is how sonographically a normal prostate appears like when using the transrectal technique. So again, with this technique, you are supposed to measure the longitudinal section, then turn your probe 90 degrees and get the transverse section for you to get the 3 measurements. Then you can measure the prostatic volume. So what are some of the common pathologies which affect the prostate? We can have simple cyst. We can have benign prostatic hyperplasia, which we call BPH, prostatic cancer, prostatitis, enlargement of the seminal vesicles. You can also have stones in the seminal vesicles, prostate, or ejaculate ducts. So you can find stones or calcifications in those organs as well. So we are now going to move on to discuss some of the pathologies which affect the prostate and their sonographic appearances. So the first pathology that I'm going to talk about is prostatitis. Prostatitis is essentially an inflammation or infection of the prostate gland. Unfortunately, prostatitis is basically not a sonographic diagnosis in the first instance. It's a clinical diagnosis that is coupled by other signs. So your doctor refers the patient for a prostate ultrasound scan suspected of prostatitis when there are complications or there are suspected complications like abscess formation. So that's when they just refer already the diagnosis that is already known. So what are the sonographic features of prostatitis? Just like any other inflammatory process, you expect to see hyperperfusion in the areas affected. So inflammation can be global, it can affect the whole organ, or it can be localized. It can be focal at one portion or one point. So in acute stages, inflammation can make the prostate gland look edematous due to inflammatory exudate. At the same time, it will be painful on sonal palpation. If you compress it, it will be tender. And then also there will be a hyperperfusion on Doppler, or what you call hyperemia. So those are some of the sonographic features of prostatitis. So in chronic stages, part of the prostate portions can undergo necrosis or they can be infarcts. At the same time, it loses perfusion when part of the cells eventually die. So you can also see some calcifications that take place due to chronic inflammation or prostatitis. So also in acute stages, let me add this. So when organ is inflamed, when it becomes edematous, it can increase in volume. So you can find an increased volume when the prostate is also infected. So the most common problem that men has, especially from 40 years and above, is what is called benign prostatic hyperplasia, BPH. So ultrasound is the second standard for the diagnosis of BPH besides the urologist's finger. So on physical examination, the urologist can palpate an enlarged prostate. That's the gold standard. Then your sonar will make a confirmatory diagnosis. So there is an increase in the volume of the prostate with a calculated volume exceeding 30 milliliters. So calculation of the prostatic volume is width times height times length times 0.52, which is the correction factor. So some scholars, they say that if the prostate is above 30 cubic centimeters, that will be BPH. Some they say above 25. But it also depends on the age of the patient. So if you see someone who is 70-year-old with a prostate that is measuring 30 ml, I think it's fairly normal, fairly within the normal range at that stage. At times also you have to work with the urologist, what they want, what are their references. So if you are working with the urologist, they can give you a table of their references so that you can use and classify enlargement of the prostate according to their own specifications. So mostly the central portion of the gland, which is called the transitional zone, is the one that is affected by BPH. And with BPH, the central zone can become more hypoechoic and can be of mixed echogenicity. You can also see calcifications that can be associated with the benign prostatic hyperplasia. So when someone's got BPH, because as the gland enlarges, it can compress the urethra and make it very difficult for one to pass urine. So it can cause urinary retention. So whenever you're doing a prostate sonar for a patient with the BPH, you must do the pre-milk volume and the post-milk volume to see if there is urine that is remaining or residual urine. So post-milk volume is usually elevated in these patients, and also when urine remains in the bladder for quite some time, it can cause infection or inflammation. Then you can see the trabeculations of the urinary bladder. You can also see the thickening of the walls. You can see sludge formation, and then you can also see associated hydronephrosis or urinary reflux back to the kidney. At the same time, the ureters can also be enlarged, a condition we call hydroureter. So these are some of the complications of BPH. So if BPH is not managed, it can also lead to renal failure, and then the patient can die. So it's not only cancer that is very dangerous. Your benign prostatic hyperplasia, if not managed, can also kill the patient. So in chronic stages, as I said, the trabeculations can become evident. Also, you can see formation of diverticulums, or diverticulitis can also be associated with benign prostatic hyperplasia. So this is an image which is showing BPH or benign prostatic hyperplasia. You can see that the prostate gland is enlarged and is invaginating the posterior wall of the urinary bladder. It's heart-shaped. So this is an enlargement that is originating from the central zone. So this is BPH, benign prostatic hyperplasia. Sorry, it's enlargement that is originating from the transitional zone. So this is benign prostatic hyperplasia. So it can be confused by some for prostatic cancer, of which prostate cancer normally affect the peripheral zone, and we will discuss about it. Again, this is an enlarged prostate from eyeballing. If you just look at it, you can see that it's enlarged. This is a transrectal image showing characteristic benign prostatic hyperplasia. You cannot see, or you are not seeing obvious lesions, but you can see that the prostate is enlarged and concentrically enlarged. This is in keeping with a benign prostatic hyperplasia. So now let's move on and discuss about prostatic cancer, which is the main subject of this module today, because it's a cancer month where we are supposed to conscientize you, the sonographer, conscientize the referring clinician, conscientize the patient, conscientize the normal person about prostate cancer, so that you have to take precautions. And if you are making a diagnosis, you must not miss prostatic cancer if it's there, if it can be seen on sonar as well. But sonography does not always see prostate cancer. But what you can see, which is macroscopic, you have to identify, and then when you see something suspicious, you also have to recommend a biopsy, or your doctor has to recommend a biopsy. So on ultrasound, prostate cancer usually appears as a hypoechoic lesion in 60 to 70% in the peripheral zone of the gland, but can be hyperechoic or isoechoic in 30 to 40% of the lesions. So essentially what we are saying here, we are saying that in most times prostate cancer appears as a lesion that is hypoechoic, mainly located in the peripheral zone of the prostate gland. So we have said before that 10% cancers of the prostate can be located in the central zone, and around 20% can be found in the transitional zone, which is a region mostly affected by benign prostatic hyperplasia. So this now brings into context why we are supposed to know the zonal anatomy, or the zones of the prostate, because we can infer if a lesion that you're seeing is cancerous or not from the zones before we order a biopsy. So also, a cancerous lesion of the prostate can be seen by chaotic flow or due to neovascularization, because the mass grows rapidly, or these malignant tumors, they grow rapidly, so they need a lot of feeding, so they tend to develop more blood vessels, and then you can see hyperperfusion on color Doppler or power Doppler. So again, this image here is just showing different types of lesions that you can see on the prostate. So you can see there's a lesion there in the peripheral zone. The first one is all inside the peripheral zone. The second one is protruding outside the peripheral zone, and the third one is also protruding and affecting the neurovascular bundles. So cancer at times, initially it can be localized, then it can spread, can move out of the prostate, then it can also invade surrounding and distant structures. It can also send meds to distant sites. So in here, let me talk about the staging of prostate cancer. Yes, using ultrasound, you can stage cancers. So stage A or stage 1 of the prostate cancer is very difficult for one to visualize it, because the anatomy or the architecture of the prostate at this stage will be preserved, and you don't see any obvious changes on the prostate. So at this stage, basically it can be detected on a biopsy, or when there's a resection during a TRUS procedure, a TAP procedure. That's when these lesions can be detected. So stage 1, basically you can't see it on sonar, just like early stages of cervical cancer, where they need the camera. That is the stage 1 or stage A of prostate cancer. Then stage B, in this case you see a palpable nodule or lesion mass which is confined to the prostate. So it will be within the prostate itself, it's not invading anything. So if you see that lesion confined to the prostate, so that will be stage 2 or stage B. So stage C, now the lesion who can extend to affect the seminal vesicles or outside the capsule of the prostate gland. So that's your stage B. You see that the lesion can send meds to the seminal, it can extend to the seminal vesicles. But now the final stage is a stage D, which is also stage 4. So during this time, the prostate cancer can extend to the rectum, also to distant sites. It can send meds, and it can also be associated with pelvic enlarged nodes. So these are some of the images showing you how a prostate cancer appears like sonographically. So a prostate cancer at times does not have rules. It's an irregular lesion. It develops wherever it wants. So it can be taller than it is wide. It can have multiple angulations. At the same time, you can see that there's going to be hyperperfusion or increased blood flow due to neovascularization. So you can see this portion here, or with the power Doppler, you can see that it's hyperperfused as compared to the rest of the gland. So this area is undergoing malignant transformation. So we can see again the first image there Your prostate is very much irregular in outline. It's no longer well outlined, and you can see that there are intraprostatic cystic spaces. If you go to the right side, you can see again there is a lesion that is masquerading as free fluid, and the lesion is irregular. On power Doppler, you can see that there is intra gland perfusion, showing that this is not fluid but it's a malignant lesion. So this is characteristic of prostate cancer. So the last image below here, you can see that there's an isoechoic lesion there. So that isoechoic lesion in the peripheral zone, this also is suspicious of prostatic cancer. You don't make a prescriptive diagnosis of prostate cancer using ultrasound, but you can make a provisional diagnosis, and then biopsy will make the confirmation. So again, this is another lesion showing prostate cancer. So with the prostate cancer, if you are going to use elastography, you can see that the tissue of the prostate, they are inhomogeneous, and they will have a variable elasticities. That's why you can see in elastography they are showing different colors. So the image below there with the presenting different colors is a cancer a cell. It is due to cancerous cells with the different elasticities, because they have a different strain and strays on the elastography. The first image up there is almost, you can see this almost homogeneous color, meaning to say that this is not affected by prostate cancer. So again, the seminal vesicles, you're supposed to know them by the sides of, on the superior lateral aspect of the prostate, you see the two seminal vesicles. Unfortunately, when they are normal at times, they are difficult to visualize on ultrasound scan, but when they are inflamed or when there are lesions inside, or when they turn cancerous, that's where they become so prominent, and you can see them on sonar. So what we are seeing here, circled by this color red, are the two seminal vesicles. So they are more prominent, they are edematous. This is in keeping with seminal vesiculitis or inflammation of the seminal vesicles. And again, when the seminal vesicles are inflamed, they can also show signs of hyperperfusion or hyperemia on ultrasound scan, and they will also be tender on sonal palpation. So lapwing many times can also be as a sequel to seminal vesiculitis. So don't ignore the seminal vesicles when you're doing a pelvic ultrasound scan. So at times you can see calcifications inside the prostate. So calcifications inside the prostate, at times they are without any clinical relevancy. So if you see the calcifications inside the central and the transitional zone, those small calcifications, they are of no clinical relevancy, and they are called the corpora amelesia. So corpora amelesia is found in most prostatic ultrasound scans that you can do. Then there are times also during which you can see them diffusely spread in the prostate. Those ones, they can have relevance. So they might occur as a sequel to chronic inflammation or prostatitis. So chronic inflammation can also cause occurrence of these type of calcifications. Or otherwise, the other small prostatic calcification that you come across, they are of no clinical relevance. So again, you can also see, or you can also find simple cysts in the prostate. They can be anywhere. So these ones, just like ovarian cyst, they are pathological in nature because they occupy space. They can also cause pain. but they are benign. So I've spoken about prostatitis. I have said that this one basically is a clinical diagnosis. So when patients come for a sauna, basically they need to rule out complications like abscess formation that can take place or that can be seen in chronic stages of prostatitis. So this is an image which is showing complications of prostatitis. So you can see there are multiple abscesses there affecting the prostate. So, and you can also see that the prostate itself is shrinking due to chronic infection or chronic injury. You can see it's shrinking in size. So you can also find calcifications affecting the urethra, or they can lodge inside the urethra. So these are called prostatic ureticular calculi. These ones can cause a problem when they block the channel, the urine channel. When they block the urine channel, they can also cause hydronephrosis. They can also cause inflammation and the retention of urine in the bladder. At the same time, they can cause diverticulums or diverticulitis to take place as well. This brings us to the end of our today module. I hope that somebody is going to benefit out of it if you take it seriously, especially the aspect of the pathology aspect. Know the variable types of pathology that you can come across before you do your prostatic ultrasound scan, else you are going to miss the pathology. Know the zonal anatomy of the prostate. Know where mostly we find the cancers in the peripheral zone. Also know benign prostatic hyperplasia, because those are some of the things that you mostly come across with on a daily basis in your respective departments. I thank you.